It's about safety.
So let's just jump right into the deep end then. I was looking through the nutritional protocols for wound healing in your source material, and I hit a contradiction that just stopped me cold.
Okay.
We have always been taught, basically since grade school health class, that protein is the king of healing. You know, protein builds muscle, protein builds skin.
That's the standard wisdom, yes.
Yeah?
Absolutely.
And then I see this protocol for burn patients. I mean, people who have lost massive amounts of tissue, and the diet recommendation is 55 to 60% carbohydrates.
Mm-hmm.
It's huge. You'd think, give them steak and eggs, they need to rebuild skin. Why are we loading them up with what, I mean, it essentially looks like a carb-heavy diet.
It jumps out at you, doesn't it? It feels completely wrong.
Yeah.
But to answer that, you have to understand the metabolic storm that happens after a major burn. We aren't just talking about a scraped knee here.
Right.
When a significant percentage of the body is burned, the body enters this hypermetabolic state. It is one of the most intense physiological states a human being can actually survive.
How?
Yeah.
How intense are we talking? Give me a comparison.
Okay. Imagine your car engine. Normal life, walking around, sitting here talking. That's like idling or maybe driving at 30 miles per hour.
Okay.
A burn patient's metabolism, starting about 4 to 12 days post-injury, is redlining. It's at 8,000 RPM, 24 hours a day.
Wow.
Their caloric needs don't just go up a little bit. They double. Sometimes they triple. I mean, they're generating mass amounts of heat and burning fuel just to stay alive and fight off infection.
So the furnace is just roaring. The body's effectively eating itself to find energy.
Exactly. Now, you're right. Protein is absolutely required to rebuild the tissue. That's your lumber. That's your structural material. You cannot build new skin without protein.
Right.
But here's the problem. Protein is metabolically expensive fuel. If you feed that patient only protein, but you don't give them enough easy, fast-burning energy, which is carbohydrates,
The body will just...
the body will take that protein you just fed them and burn it for heat.
That seems incredibly inefficient.
It's a waste. It's a survival mechanism, but it's wasteful. This is where the concept of protein sparing comes in. We flood the system with carbohydrates. That's the firewood.
Yeah.
We want the body to burn the carbs for energy. That allows the protein they ingest to be spared for its actual job, structural repair.
I love that analogy. If you don't provide the firewood, you're essentially chopping up your log cabin just to keep the fireplace going.
That is a perfect way to visualize it. And that's why if you see a question asking why a burn patient is on a high-carb diet, the answer isn't about blood sugar.
Right.
It's about sparing protein for tissue synthesis.
That is a crystal clear distinction. So the carbs keep the lights on and the protein rebuilds the walls.
You got it.
Now, speaking of rebuilding, the guide lists a specific alphabet soup of vitamins required for wound healing: A, C, K, and B12.
Mm-hmm.
I want to move past just memorizing the letters. What is the mechanism here? Let's start with vitamin C.
Vitamin C is the glue. We tend to think of it for, the common cold, but its real superpower is collagen synthesis.
The glue, okay.
Biochemically, collagen, which is the main structural protein in your skin, connective tissue, it forms this triple helix structure. Think of it like a braided rope.
Mm-hmm.
Vitamin C is a necessary cofactor for the enzymes that stabilize that helix.
So without it, the rope just unravels.
Essentially, without vitamin C, the new tissue is weak. It's unstable. The wound literally falls apart. This is actually what scurvy is, old wounds opening up because the collagen degrades.
That is a horrifying image, but I will not forget it. It's structural cement. What about vitamin A?
Vitamin A acts like the general contractor on the job site.
Okay.
It drives epithelialization. It signals the skin cells to migrate across the top of the wound and close it up. It also it ramps up the inflammatory response. Now, usually we think inflammation is bad.
Right, anti-inflammatory.
But in a wound, you need that initial burst of inflammation to clear out debris and bacteria. Vitamin A manages that whole process.
And vitamin K, I usually associate that with blood thinners, clotting.
Which is exactly why it's on the list. You cannot heal a wound that is actively bleeding.
Of course.
You need to stop the flow first. Vitamin K is essential for the synthesis of prothrombin and other clotting factors in the liver. It creates the fibrin mesh, the scaffolding that the new tissue builds upon. If you don't have that mesh, you have nothing to build on.
Then we have vitamin B12. This one seems to pop up everywhere in clinical medicine. Why is it vital for a wound?
B12 is crucial because it's involved in DNA synthesis and, critically, red blood cell formation. Think about it. How do nutrients and oxygen get to the wound site?
Through the blood.
Right. If you're B12 deficient, you can become anemic. If you're anemic, you aren't carrying enough oxygen. And if you aren't carrying oxygen to the wound bed, Well, nothing happens. The construction crew suffocates.
Wow.
You need B12 to keep the supply lines open.
That's a perfect segue to the enemies of healing. We've got the toolkit protein, carbs, vitamins, but the source material highlights two major physiological conditions that absolutely wreck this process: diabetes mellitus and smoking.
Mm-hmm.
Let's drill into the mechanics of diabetes first. We all know diabetics heal slowly, but why? What is actually happening in the tissue?
It's a three-pronged attack on the body's ability to repair itself. It's brutal. First, you have the vascular issue.
Right.
Chronic high blood sugar damages the endothelial lining of blood vessels. They narrow, they harden, and they lose flexibility.
Oh.
So physically, you just cannot get adequate blood flow to the periphery, like the toes or feet.
So no blood means no antibiotics, no oxygen, no nutrients.
Exactly. That's the supply line problem again. The road is blocked.
Right.
Second is neuropathy. High sugar is toxic to nerves. Patients lose sensation. I mean, I've seen patients walk around for days with a nail in their shoe or a blister from a new boot and not even know it.
They feel nothing.
Nothing. By the time they see the blood on their sock or, smell the infection, it is already spread to the bone.
That is terrifying to just not know you are injured.
It really is.
Yeah.
And the third prong, this is the one people often forget. Hyperglycemia effectively paralyzes the immune system. Specifically, it impairs the function of white blood cells called neutrophils. They can't perform chemotaxis. They can't swim effectively to the site of bacteria. So let's put it all together. You have a wound, you can't feel, it's getting no blood, and your immune system is too sluggish to fight the bacteria that got in.
That explains why it's a leading cause of amputation. It's just a perfect storm for tissue death.
It is.
Now, moving to the other enemy, smoking. The guide lists it as a massive contraindication for wound healing. Is it just the general toxins, or is there specific physics involved here too?
Oh, it's very specific physics. Smoking does two things that directly counteract the healing process. First, nicotine is a potent vasoconstrictor.
Yeah.
It clamps down on the blood vessels, similar to the diabetes issue, but acutely. You smoke a cigarette, and your peripheral blood flow drops immediately.
So you're choking off the supply line again.
Correct. But the second factor is carbon monoxide. When you inhale smoke, carbon monoxide enters the bloodstream. It binds to hemoglobin, the oxygen taxi in your blood, with an affinity that is roughly 200 times stronger than oxygen.
200 times. So it's a bully.
It's a massive bully. It kicks the oxygen right out of the seat.
Wow.
So even if blood is reaching the wound, that blood is carrying carbon monoxide instead of oxygen. You create local tissue hypoxia. And on top of that, chemicals in smoke are directly toxic to fibroblasts.
And the fibroblasts are the cells that lay down the collagen?
They're the builders.
So let me summarize this disaster. You shut down the road with vasoconstriction, you replace the oxygen in the trucks with poison gas, and then you shoot the construction workers, the fibroblasts, who are supposed to do the work.
That is a painfully accurate summary of smoking and wound healing. It is the single best thing a patient can stop doing if they want to keep their limb.
All right, let's shift gears. We're moving from the body to the brain. This section on altered mental status is critical because it's so easy to misdiagnose. And the consequences, they can be fatal. We're talking about the battle between delirium and dementia.
This is one of the most important distinctions in nursing practice. They can look identical from the doorway.
Yeah.
You see a confused older adult who doesn't know where they are. But one is a chronic condition and the other is a medical emergency.
The guide uses this phrase, acute confusion plus older adult equals delirium until proven otherwise.
Why is that the default assumption? Why not assume it's just aging?
Because delirium is almost always a symptom of an underlying physiological problem. It's the brain's way of saying, help, something is wrong with the body.
Okay.
It could be a urinary tract infection, pneumonia, dehydration, a drug interaction, an electrolyte imbalance. If you label it dementia and ignore it, you might miss a septic patient. You have to assume it's fixable and find the cause. So how do I tell them apart clinically? If I'm talking to the patient, what are the red flags I'm looking for?
Okay, start with the onset and the attention span.
Yeah.
Delirium is acute. It happens fast. Hours to days.
Hours to days.
One day, grandma's doing her crossword puzzle and is totally fine. The next day, she's talking to people who aren't there. And it fluctuates. This is key.
Mm-hmm.
They might be lucid in the morning and completely disoriented by dinner. This is where we get the term sundowning,
Right.
confusion that worsens as the day goes on or when the lights go down.
Okay, so sudden onset and it comes and goes. What about dementia?
Dementia is a slow burn. It's chronic, progressive, and irreversible. It happens over years. You see a gradual decline. But the biggest clinical pearl, the thing that helps you distinguish them in the moment, is the level of consciousness, or LOC.
Break that down for me.
In a patient with dementia, even if they are confused about the year or they think you're their niece when you aren't, they're usually alert.
Okay.
They're looking at you, they're engaged, the lights are on, even if the filing system is messy.
Whereas in delirium,
The LOC is altered. They aren't fully there. They might be lethargic and hard to rouse, or they might be hyper-agitated and climbing out of bed. They cannot focus attention.
right.
If you ask a question, they drift off before answering. If you see an older adult who is suddenly drowsy and seeing spiders on the wall, that is delirium. That is an emergency.
That distinction, alert but forgetful versus drifting and hallucinating, is really helpful. It gives you a concrete thing to look for in their eyes.
Exactly. And remembering that delirium is reversible is what drives you to check the labs, check the urine, check the meds.
Let's move on to segment 3. We are transitioning from the brain to the med cart. We've got 3 heavy hitters on the docket: metformin, prednisone, and morphine. These are drugs nurses give every single shift, millions of times a day.
And because we give them so often, we can get complacent. We go on autopilot. But these drugs have very specific stop signs, red flags, that if you miss them can cause serious harm.
Let's start with metformin. It's the bread and butter for type 2 diabetes. How does it actually work?
It's a pretty smart drug, actually. It works primarily in the liver. It tells the liver to stop producing excess glucose, a process called gluconeogenesis.
Okay.
It essentially says, hey, we have enough sugar, stop making more. It also increases insulin sensitivity at the cell receptor site, so the insulin the patient does make works better. And lastly, it slows down glucose absorption in the gut.
Ah, that gut part explains the side effects, right?
Yeah.
The guide lists GI issues, flatus, anorexia, nausea as the #1 complaint.
Oh, yes. Bloating, gas, diarrhea, it's infamous for it. It usually settles down after a few weeks, but it can be really rough for patients starting out. It also causes a metallic taste in the mouth. And connecting back to our first segment, long-term metformin use can inhibit the absorption of vitamin B12.
There's that ripple effect again. Treating the diabetes can cause the B12 deficiency that hurts wound healing. Wow.
It's all connected.
Now, the big exam question and the big safety question for metformin is always the contrast dye rule.
This is non-negotiable. If a patient on metformin needs a CT scan with iodine contrast, you must stop the metformin, usually 24 to 48 hours before, and definitely for 48 hours after.
Why? What is the interaction? Is it some sort of chemical reaction?
It's all about the kidneys. Iodine contrast is nephrotoxic. It's hard on the kidneys. It can cause a temporary acute kidney injury, or AKI.
Okay.
Now, metformin is cleared by the kidneys. If the kidneys stall or slow down because of the dye, the metformin isn't excreted. It builds up in the blood to toxic levels. This leads to lactic acidosis, which has a very high mortality rate.
So the nurse has to be the gatekeeper. The radiologist might not know the patient took their metformin that morning.
Correct. You are the goalie. You hold the med, and you don't just restart it 48 hours later automatically. You check the creatinine level first. Only if the kidney function is back to baseline do you restart the med.
Next up, prednisone. The corticosteroids. I feel like we hand these out like candy for inflammation, but the side effect profile is basically a list of everything you don't want.
It's the ultimate trade-off drug. It shuts down inflammation for asthma, COPD, autoimmune flares, better than almost anything else. It is a miracle drug in that sense.
Right.
But the cost is high. It affects almost every system in the body.
Let's run the list of what we need to watch for. Hyperglycemia seems to be the big one.
Huge. Prednisone causes the liver to dump glucose and makes cells resistant to insulin. Even a non-diabetic patient can see their blood sugar spike to 300 or 400 on high-dose steroids.
Wow.
You have to monitor glucose even if they've never had a sugar problem in their life.
And immune suppression.
Well, it works by suppressing the immune system, which is great for autoimmune diseases, but it puts the patient at high risk for new infections. You have to watch for fever or any subtle signs of illness.
What about the physical changes? The guide mentions moon face.
Yeah, we call it a Cushingoid appearance. Long-term use causes fat redistribution to the moon face and the back of the neck, the buffalo hump. It also thins the skin and weakens the bones, leading to osteoporosis. It leaches calcium right out of the skeleton. It can also cause peptic ulcers, so we usually give it with food.
But the most critical safety rule regarding prednisone isn't about the side effects while taking it. It's about stopping it, the taper.
You must taper corticosteroids. You cannot just stop cold turkey. Here's the physiology. When you take prednisone, you're taking exogenous cortisol.
Right.
Your body looks at that high level in the blood and says, oh, okay, I don't need to make any. Your adrenal glands basically go on vacation. They atrophy. They go to sleep.
So if you stop the pill cold turkey,
Your adrenal glands are asleep. They can't wake up fast enough to produce the cortisol you need to survive. You go into an Addisonian crisis, also called adrenal crisis, severe hypotension, vascular collapse, shock. It can kill you.
so you have to wean them off.
You have to wean the dose down slowly. Taper it to let the adrenal glands wake up and get back to work.
That's a life-saving education point for the patient. If they say, I hate the way this makes me feel, I'm flushing them, you have to intervene.
Absolutely. Stopping abruptly is dangerous.
All right, third drug, morphine, the gold standard opioid.
Morphine binds to mu-opioid receptors in the central nervous system.
Yeah.
It blocks the pain signal, and it alters the emotional response to pain. But those same receptors also control the respiratory drive in the brainstem.
Which leads to the big warning label, respiratory depression.
That's the killer. The rule of thumb is, check the respiratory rate. If it is 12 breaths per minute or lower, you hold the drug. You do not give it.
Why 12? I mean, why not wait until it's lower?
Safety margin. If they're breathing at 12 and you give them a dose, you might push them to 8. If they're at 8 and you give them a dose, they might stop breathing entirely.
Got it.
You also have to watch for hypotension. It dilates blood vessels, and constipation. The bowel goes to sleep just like the brain does.
The guide lists head injury as a specific contraindication. That seems oddly specific. Why head injury?
This is a nuance about diagnostics. In a head injury patient, the most important thing we monitor is their level of consciousness. Is the brain swelling? Is the intracranial pressure going up? Is the bleed getting worse? The only way we know is if the patient gets confused, drowsy, or unresponsive.
And morphine makes you confused, drowsy, and unresponsive.
Exactly. If you give the morphine, you mask the symptoms. You lose your early warning system. You don't know if they're lethargic because of the drug or because their brain is herniating.
Wow.
So we avoid opioids in those acute assessments if possible, or use very short-acting ones.
That makes perfect sense. You don't want to fog up the window you're trying to look through.
Precisely.
Let's move to segment 4, critical care and emergency management. When the wheels really fall off, we have two scenarios here. First, DKA diabetic ketoacidosis.
This is typically a type 1 diabetes complication.
Yeah.
It's a metabolic crisis.
Yeah.
The body has no insulin.
None.
No insulin means the sugar can't get into the cells, so the cells starve. The body panics and starts burning fat for fuel. The byproduct of burning fat is ketones, and ketones are an acid.
So the blood turns acidic, and the sugar is sky high because it's just stuck in the blood.
Correct. The patient becomes dehydrated, acidic, and hyperglycemic.
The fix is insulin. The guide says regular insulin via continuous IV infusion.
Specifically regular insulin. That's the only one we give IV. We run it at 0.1 units per kilogram per hour. But here's where the art of nursing comes in. You are dropping that blood sugar, but you cannot just drop it to normal and turn off the pump.
Right. The guide mentions a glucose crash protocol. It says when glucose hits 200 millibl, you don't stop the insulin. You actually add sugar to the IV fluids. You add dextrose.
It sounds backwards, right? Why am I giving sugar to a diabetic with high blood sugar?
Yeah.
But here's the logic. The problem in DKA isn't just the high sugar. It's the acidosis, the ketones. And it takes longer to clear the acidosis than it does to lower the sugar.
I see. So the sugar drops fast, but the acid takes time.
Exactly. You might get the sugar down to 200 in 6 hours, but the patient is still acidic. If you turn off the insulin, the acidosis will bounce right back. So you keep the insulin running to treat the acid, but you add dextrose to the IV to cover the insulin and prevent hypoglycemia while you finish treating the acidosis.
You're balancing the scales, keeping the engine running to burn off the acid, but adding fuel so it doesn't stall out.
That's a great way to put it. And ideally, you want to drop the glucose slowly, about 50 to 75 milligrams per hour, too fast. And you can cause fluid shifts that lead to cerebral edema brain swelling.
Now, there is one more trap with DKA that the guide highlights, and it scares me. The potassium trap.
This is the silent killer. It's basic physiology, but it's lethal if you forget it.
Okay.
Insulin acts as a key that opens the cell door for glucose. But potassium's a hitchhiker. It goes to that same door. When you give IV insulin, it pushes potassium out of the blood and into the cells.
So the serum potassium level drops?
Rapidly. And if it drops too low hypokalemia, you get leaky heart arrhythmias. The heart relies on potassium to beat.
Mm-hmm.
So before you even start the insulin drip on a DKA patient, you look at the potassium level. If it's below 3.3, you hold the insulin.
Even if the sugar is 500?
Even if the sugar is 800, you have to fix the potassium first. If you start insulin on a patient with low potassium, you could stop their heart.
That is a massive prioritization point. Dead heart beats high sugar every time.
Always. You treat the most immediate threat to life.
Okay, second emergency, malignant hyperthermia. This sounds like a horror movie title.
It can be a horror show in the operating room.
Yeah.
It's a rare genetic reaction to certain anesthetics,
Okay.
specifically to the acetylcholine, which is a paralytic, and inhaled gases. In susceptible patients, these drugs cause the muscle cells to release massive amounts of calcium from storage.
And calcium makes muscles contract.
Right, but this is uncontrolled. The muscles become incredibly rigid, they contract sustainably. This burns massive amounts of energy and generates incredible heat. The patient's temperature can spike to lethal levels, hence hyperthermia. We're talking 105, 108 degrees Fahrenheit, rapidly.
And the antidote is dantrolene.
Dantrolene is the only drug that fixes this. It's a skeletal muscle relaxant that works by directly inhibiting calcium release in the muscles. It stops that rigid contraction that's generating all the heat. It turns off the furnace.
The guide has a couple of specific nursing education points for dantrolene. Watch for liver disease and photosensitivity. That's an odd one.
Yes, it can cause liver damage, so it's contraindicated in active liver disease, and oddly enough, it makes patients very sensitive to the sun. So if you're discharging someone on oral dantrolene to prevent recurrence, you tell them to wear sunscreen, wear long sleeves, and avoid the beach. It's a weird side effect, but good to know for exams.
Good to know. Okay, take a deep breath, everyone. We have arrived at segment 5, the math portion.
Don't panic, it's just multiplication.
Burn management and fluid resuscitation. So we need to calculate how much fluid a burn victim needs to survive the first 24 hours. But first, we need to know how much of them is burned. This is the rule of nines. Let's visualize this.
Okay, we divide the body into sections that represent roughly 9% of the total body surface area, or TBSA. The head and neck, front and back combined is 9%.
Head is 9. Got it.
Each entire arm, shoulder to fingertips, is 9%.
So head is 9, right arm is 9, left arm is 9. Easy so far.
Now the torso. The trunk is bigger. The entire front, the anterior trunk, so chest and abdomen is 18%.
Okay, 18.
The entire back, the posterior trunk, is also 18%.
That's a lot of surface area. And the legs?
The legs are bigger than the arms. Each entire leg is 18%.
18 each.
And finally, the perineum, the groin area, is that last 1%.
So let's do a quick scenario. A patient has burns on their entire left leg and their entire front torso.
Okay. Left leg is 18%. Interior trunk is 18%. 18 plus 18 is 36%. So they have a 36% TBSA burn.
Exactly. And once you have that number, that 36%, you plug it into the Parkland formula to figure out how much fluid they need to survive the shock.
Correct. The formula is 4 milliliters C weight in kilograms times the percentage of the burn.
And the fluid of choice?
Lactated ringers. We use LR because it's an isotonic crystalloid that is most similar to blood plasma, and it helps buffer the metabolic acidosis we talked about earlier.
Right.
Normal saline can actually make the acidosis worse in these massive volumes.
So let's do the math. Let's say we have an 80-kilogram patient with a 50% burn, just to make the numbers round.
Okay.
That's 4 milliliter times 80 kilogram times 50.
That equals 16,000 milliliters. That is 16 liters of fluid.
That is a massive amount of fluid. I mean, if you poured 16 liters of water on the floor, it would flood the room. How do we give it?
This is the clock rule.
Yeah.
And it's the most common place students lose points and where patient safety is compromised.
Okay.
You have to give the first half of that total volume in the first 8 hours. The remaining half goes in over the next 16 hours.
So in our example, 8 liters in the first 8 hours, that's a liter an hour. But here's the expert note pointed out. The clock starts when?
The clock starts at the time of the burn injury, not the time they arrive at the hospital.
That is huge. So if the patient was burned at 12:00 p.m., but they don't get to you until 2:00 p.m.
You were already 2 hours behind. The first 8 hours window ends at 8 p.m., which is 8 hours from the injury. It doesn't end at 10 p.m. So now you don't have 8 hours to give that first 8 liters. You only have 6 hours.
So you have to run the pump faster.
Significantly faster to catch up.
If you calculate it starting from arrival time, you will under-resuscitate them.
Exactly. And if you under-resuscitate, their blood pressure drops, perfusion fails, and their kidneys will fail. In burn care, urine output is the gold standard. We want to see at least 30 to 50 milliliters per hour of urine. If you aren't getting that, you crank up the fluids.
It's a race against time and physiology.
It is. The math is easy. The timing is critical.
We have covered a massive amount of ground today. I mean, from the cellular alphabet soup of vitamins to the life or death math of burn resuscitation.
And if there's one theme to take away, it's that the body is an interconnected system. You can't treat a wound without thinking about nutrition. You can't treat diabetes without thinking about the kidneys. You can't treat pain without thinking about the lungs.
Whether it's counting a respiratory rate before giving morphine or checking potassium before starting an insulin drip, the nurse's job is vigilance. It's catching the subtle signs before they become sirens.
That's the job. It's not just following orders, it's understanding the why so you can keep the patient safe.
You know, before we sign off, I'm stuck on one thought. We started talking about how vitamin B12 is essential for wound healing. And then we learned that metformin, the drug used to treat the diabetes that caused the wound in the first place, can actually deplete vitamin B12.
It is a fascinating, cruel irony, isn't it?
It really is. It makes you realize how every single intervention has a ripple effect. You fix the sugar, you might starve the wound. It really highlights why you have to look at the whole patient, not just the diagnosis.
An important thought to end on.
That's it for this deep dive. Good luck on the exam, and more importantly, stay curious out there.
Take care.